Zax, over to you to tell us all about adolescent health. Thank you very much.
Thank you so much, Prof, for that lovely introduction. Good afternoon, everyone. I'm actually going to switch my video off. Yeah, that's much better. So thank you, everyone, for joining us on a Wednesday afternoon at 5 o'clock. I know it's always a difficult time of the week and a difficult time for us to get together, but I do appreciate everyone being here. And as Prof. McCullough said, today we're going to spend a bit of time just mulling over adolescent health and the challenges in setting up adolescent services and what exactly it means to be offering adolescent services in the context that we find ourselves. So on June the 16th, we honored Youth Day in South Africa. It's a day that we should all pause to reflect on June the 16th, 1976. This we know was a day of youth uprising against the apartheid regime. And it's a day that most of us associate with a very famous, very iconic picture taken by celebrated photographer Sam Mzima. It's a photograph that evokes a lot of emotion, as it rightly should. But fast forward to June 2022, 46 years have lapsed, and the future of South Africa's youth is even bleaker than it was on that fateful day in 1976. This slide reflects some comments from an article in the Daily Maverick from June the 16th, 2022, when a journalist interviewed youth in Orlando, Soweto, and these are just some of their comments. After 28 years of freedom in South Africa, young people in Orlando, Soweto are still struggling. I've highlighted the issues that the learners or the young people who had been spoken to had brought to the front. And as you can see, I quote, "Literacy is a big problem in our schools. Most learners are struggling to read. I suggest that some people should be employed to help them. Bullying is the most common problem. We need psychologists in our schools. There is a lack of confidence due to a lack of trained educators. Low self-esteem is the problem as well." Another young person commented that girls these days are leaving school and ending up falling pregnant. "If I can be a president for a week, I would like to encourage people to get counseling. I will build more RDP homes because people are sleeping in the streets. The education system needs to be fixed. Marijuana is a problem in our schools," said another learner, "and it's bad. School furniture is not enough. Our youth, they don't go to school. They party and they drink a lot. We have a lot of peer pressure. There's a lot of bullying at our school. And as the youth of today, we have peer pressure. Some of the teachers are discouraging learners, and homelessness is a big problem. Some of our youth are struggling with their identity and they just don't appreciate themselves." So these comments are rather harrowing. And I can't help but think that whilst these are voices from Soweto, South Africa, they actually echo what I hear in my clinic in Hanover Park each week and what I'm hearing at the Adolescent Center every day. Our South African youth are crying out for help. I think we can't allow this moment to pass without reflecting on the absolute tragedy that took place in East London this past weekend, where 22 young adults, the youngest of whom was 13, were actually found dead in a shebeen in the early hours of Sunday morning. And I couldn't help but think, what was a 13-year-old doing in a shebeen on a Saturday night? So recent statistics have shown us that adolescents make up 18.5% of our total population. And it is estimated that the adolescent population will continue to increase through to 2050, highlighting the need to make this population group a healthy one. We need to invest in adolescent health and well-being now, as it's critical because 35% of the global burden of disease has its root in adolescence. Despite the increasing focus on adolescent health and well-being, there has, however, been little progress in achieving universal health coverage for adolescents. Our country is known for its robust policies and initiatives that stem from the human rights perspective reflected in our country's constitution, and this includes initiatives to promote access to high-quality healthcare for adolescents. In the article on the right, which I recommend everyone read, the authors state that despite an enabling policy environment for adolescents in South Africa, there have been numerous foundational challenges across the health system. These include challenges with governance, medicine and technology, human resources, service delivery, lack of adolescent-specific indicators in data information systems, and systems financing. These elements are key in achieving universal health coverage, and without strengthening them to ensure that interventions to improve adolescent care are prioritized across the health system, achieving universal health coverage for adolescents will continue to remain a challenge for us in South Africa. So the challenges we face are huge. One example is that South Africa has a very high proportion of NEET adolescents. Those are adolescents who are not in employment, education, or training. This is a social determinant of health. And one of our efforts at achieving universal health coverage for adolescents will depend on the progress we make at reducing the number of NEET adolescents in South Africa. Easier said than done, isn't it? But all hope is not lost. And the sun rises each day and ushers in a lot of hope. Government investment into adolescent care is critical, as the spin for the future is huge. After all, healthy adolescents today will mean healthy, productive adults tomorrow, who are able to participate and contribute meaningfully to the society and economy at large. Such an investment requires a huge buy-in from multiple sectors, and in fact, not just buy-in, but commitment. So the Western Cape Department of Health and Wellbeing and Reproductive Hospital have taken the lead and shown such commitment with the launch of the Reproductive Adolescent Center of Excellence. And after courting numerous COVID-related delays, we officially opened our doors to the public in July 2021. So situated in Rondebosch, not far from the Red Cross Children's Hospital, the Reproductive Adolescent Center of Excellence is a grand old lady converted into an adolescent-friendly space for adolescent and youth-friendly medical services. The idea is that it will become a one-stop shop for general adolescent medical care, including subspecialty clinics, mental health services, including psychiatry clinics led by the Grooteskier psychiatric team, as well as counseling services provided by the Youth Hub at SACAP. And very excitingly, a multidisciplinary fit club, which I will speak about a little bit later. It's been a whirlwind few months, with the clinic steadily picking up pace and becoming busier and busier. So let's cast our mind to the actual adolescent patient. What makes them so special? To start off, they are not big children, nor are they little adults. Adolescence is a period of immense physical and emotional change, and the variation in timing of these changes is huge. So one may encounter several 14-year-olds, a room full of them, who are at very different stages of physical, mental, and emotional development. Just take a moment and think back to when you were 14 years old. Would that be a time in your life you would willingly return to? I'll leave the answer to yourself. Try to bring that empathy back into the consulting space with the adolescent that you see. The adolescent patient may be a patient who has lived with a long-term health condition and is completely comfortable in the healthcare space. Or it may be a young person presenting with a fresh medical condition or a concern, having never accessed public or private health services ever, if not in a long time. Either way, they may be extremely shy about being at the clinic. They often feel embarrassed that they are seeking care. They may worry that they may not be able to articulate their concerns adequately, and they may feel quite anxious about something being seriously wrong with them. They may feel intimidated by us. They may come in there very defensive and even be totally resistant to receiving help. They may be there simply because an adult has coerced them into coming. So how do we as service providers make that process easier for them? Number one, all of us, we need to be a youth champion and treat them with respect. Number two, be open to all their questions. Number three, use non-judgmental words and body language. Number four, use language and words that they can understand and relate to. Number five, ensure their privacy at all times. Number six, reassure them of confidentiality, as this is a huge concern to many teenage patients. And number seven, very importantly, we need to remember to tailor care the individual, to tailor our care to the individual in the room. We simply cannot use a one-size-fits-all approach, as adolescents differ from one another in so many ways. So what exactly constitutes adolescent-friendly health services? Ideally, they are facilities designated for the youth. They are youth-friendly, they have convenient hours, they are conveniently located, they have comfortable youth-friendly surroundings with short waiting times where their privacy and their confidentiality is ensured. These are just a few pictures from inside the Adolescent Center, and you can see how even small words of inspiration are incorporated into the physical space that meets the adolescent when they come for care. So adolescent-friendly services per se are not new to the South African health system. The concept was rolled out a good few years ago, but no evidence actually exists that the clinics implementing adolescent youth-friendly services provide more adolescent responsive or high-quality care than those yet not implementing it. So an evaluation of adolescent youth-friendly service health facilities in Gauteng and Northwest Province done back in 2015 actually found that none of the service providers were meeting the minimum standards required of an adolescent and youth-friendly service. Furthermore, despite the Adolescent and Youth-Friendly Services Initiative and the Adolescent Sexual and Reproductive Health Rights Policy, adolescents still have a high unmet need for contraception and a high prevalence of unintended pregnancy. Maximizing our efforts to improve access to sexual and reproductive health services for adolescents holds the potential to reduce unintended pregnancy and unsafe abortions, while simultaneously improving reproductive health and safer contraceptive options to many teens who are sexually active. So this is just an example of what some visible signage in an adolescent youth-friendly service clinic or area should say. Introducing ourselves, it says that you are entering and we are offering youth-friendly services, and what that means is introducing ourselves, asking you what you like to be called, explaining that the visit is confidential, creating an open atmosphere of trust, listening, respecting diversity, avoiding gender and sexuality stereotypes, empowering you, the patient, to make your own decisions by offering support, not opinion, remembering that body language talks, no judging and no funny looks, providing clear, thorough explanations, referring you to other medical professionals or places if needed, saying goodbye and reminding you that we are here for you. And what I really liked is this one. If your expectations weren't met or we exceeded your expectations, please give us your feedback. All well and good, I hear you say. Recently, I partook in an interactive session with the city clinic service providers who are really trying hard to promote youth-friendly services at their clinics in Cape Town. And for some reason, the uptake seems poor. And my thoughts around that are that adolescents simply do not like attending a facility where there are other older patients. They associate day hospitals and big hospitals with old people and being sick. And this is just not cool when you are 14 or 15. Some of the positive comments I've received at the Adolescent Center: this is awesome, it's not as noisy as Red Cross. Or, sure, it's so nice to not sit amongst crying babies. It's lovely to not have to wait in a queue, for example. So hopefully we are doing something right there. So what exactly is on offer at a center like ACE, you may be wondering. So apart from general adolescent medical clinics, which are run by myself, we have a dedicated adolescent renal clinic looking after non-transplant patients who have outgrown Red Cross, but still need specialist care. And that clinic has been coordinated by Prof. McCullough and myself. There are plans underway to expand the provision of other adolescent subspecialty clinics at ACE. We have an adolescent psychiatry clinic once a week, supported by counseling services provided by SACAP's Youth Hub at ACE, and that's on a daily basis. The endocrine team run a dedicated adolescent transgender clinic at the ACE Center once a month with a recently launched transgender support group. And finally, we have an established Fit Club, which is a multidisciplinary service incorporating a doctor, an occupational therapist, a physio, a dietitian, and a counselor to address the growing obesity epidemic amongst young adults. The SACAP Youth Hub team is also hard at work at planning the rollout of several support groups, one for adolescents with long-term health conditions, another for parents and families of adolescents with long-term health conditions, as well as the depression and anxiety support groups. And the need for these groups have come up after being in business for a year, and based on our stats and where we see the greatest need has arisen. We furthermore identified a need for a teenage mom support service, which is different to a support group. The big aim of which will be to ensure that our teen moms, A, get back to school, B, get assistance with things like an ID and birth registration for the infants, which many of them struggle with, to provide general psychosocial support, as well as much needed contraceptive advice and access at ACE. Our Fit Club, very exciting space. So we will conclude the first cohort of patients enrolled into Fit Club at the end of June. With 23% of adolescents in South Africa being overweight and roughly 7% of them obese, the need for this clinic spoke for itself. Results in our first cohort have been mixed, and we have lost and gained along the way. Fit Club has forced me, as well as the team, to rethink our approaches and strategies to promoting healthy eating and a healthy lifestyle in this very vulnerable group. Just being able to offer support in the way of a multidisciplinary team has been phenomenal. Ensuring that each patient has a mental health screen, in addition to being offered a diet sheet, has actually been phenomenal. Seeing the smiles on their faces when they arrive for the exercise sessions has been heartening. And sometimes, even though the needle hasn't shifted on the scale, just seeing them feel better about themselves has been hugely rewarding. So no talk about adolescent health will be complete without addressing mental health. And with suicide being the third most common cause of death in this age group, it is cause for great concern. The pandemic and lockdown have hit our adolescents hard, and no doubt many of us are seeing the fallout in terms of accelerated anxiety and depression amongst teens. We need a space where we can encourage the building of resilience and not only resistance. The ACE Center provides a confidential, safe space to address many mental health concerns. The referrals I receive are often for patients with underlying chronic health conditions, but an increasing number of referrals with young adolescents with new onset mental health symptoms. Depression, anxiety, self-harm, eating disorders, and addictions are the top 5 conditions seen at the center to date. We need to destigmatize adolescent mental health and promote access to care. More than 50% of all adult mental health conditions originate in adolescence. We need to normalize discussion around it and empower our families to be on the lookout for telltale symptoms and signs of an emerging mental health condition in their teens. Families provide the foundation for child and adolescent mental health. And while schools are ideal spaces to address mental health, schools can be equally stressful in terms of bullying, corporal punishment, inter-pupil violence, etc. So as pediatricians, we need to be the service providers who will not shy away from this problem. So the latest edition of the Child Gauge focuses entirely on child and adolescent mental health. And this is another must-read for everyone here. So looking ahead, what's up ahead for people who are interested in adolescent health? There's a short course in adolescent health that is being developed currently and will be on offer from UCT and the School of Child and Adolescent Health. Prof. Tony Westwood, Dr. Adelaide Masu, and myself, we are working out the nitty-gritties of this course, and we are hoping to flight it for the first time early in 2023. We are looking to develop a curriculum on adolescent medicine, recognizing the gaps in our pediatric training and even our training of our physicians. We are looking to growing ACE into a true center of excellence, not just in terms of the care delivered, but in terms of access to a host of adolescent-specific services, and looking to see ACE become a model of adolescent healthcare delivery that can be duplicated elsewhere. So on that note, I think I'll hand over to my colleague, Rebecca Sher, who runs an amazing adolescent ID clinic at Grooteskier Hospital. Rebecca will speak to us about the challenges faced in caring for an adolescent patient with a long-term health condition, a full topic for discussion on its own. Thank you for your time. I will be available for comment or questions at the end of the session.
Thanks very much, Zax. That was really great. I'm actually just going to add a few comments because I know that we've got a bit of extra time before we hand over to Rebecca. So A couple of the specialties have quite a lot of challenges transitioning pediatric patients across to the adult services. So in our pediatric services, our numbers are small. We all get involved with the families, and so the patients, if they don't come to clinic, they'll often get phoned. So if you take, for example, the renal clinic, if they don't come in, we'll get onto their case and we'll give them a ring and ask why they haven't come to clinic. You move fast forward into the big adolescent world, and they often have 200-300 patients in a clinic. If somebody doesn't come to clinic, nobody's going to be chasing them up. And in the renal world, specifically, if you're dealing with children who've got end-stage kidney disease, who may need to go onto a waiting list, not just for a transplant, but even just for a dialysis slot. If you're a person who's having to make decisions about these, and you've got, for example, 10 patients, adults and adolescents, who you need to decide who gets the dialysis slot, the difficult teenager, and I'm going to call it difficult in inverted commas, is the one person that really would struggle to get that slot. And that's where we've really found it difficult. We've often looked after these children for more than their 13 years. We are very lucky. Our hospital looks very kindly upon these kids, and so we say they're 12 years and some 48 months or 60 months. And then when we send them to the adult services, often they really have a tough time settling in. We've been very lucky in that our adult renal colleagues have worked with us together, and they've actually been very good about trying to give these kids an extra chance. But there's definitely a big step between pediatrics, adolescents, and then the adult world, as you've explained. And I did some research recently. During the year of COVID last year, there were 23,000 teenage pregnancies in our country, which is just a staggering number. And I can really relate to that because two of my own patients who were 16 or 17 came in with, the one's complaint was a bit of extra gas in her abdomen, and the other one just came in saying she'd put on quite a lot of weight. And in fact, both those symptoms were indicative of another little person coming into this world. And so we've really had to struggle with chronic patients who now, as you say, become teenage mums and really struggling with this whole concept of COVID. So, and the whole depression that goes with COVID. So having a chronic illness, having COVID, having depression from COVID, having teenage pregnancies, I just think there's a really big gap in our chronic care service between pediatrics and the adult world. And it for me, it's just so refreshing hearing the work that you're doing and watching and seeing the work that you're doing. It's really been amazing that the patients we've referred to have just loved coming to you. And also the Fit Club, I think, is a really, also, having children who are problems with being overweight, self-esteem, and then trying to lose that weight. We often see them because they get referred to us with high blood pressure related to their overweight state. So I think you've done some brilliant work. If you said if you were president for a day, for a week, you gave us some ideas. If you were to draw up a curriculum, and I know you are doing that with Tony Westwood, what do you think we should be teaching in our medical schools, and what should we be teaching in our pediatric subspecialization degrees?
So I think, first of all, one of the, I think across the board, if we think about adolescents want to be heard, but there's also specific nuances around communicating with them. So I think getting the communication right and engaging with them in a way that they actually feel validated and they feel heard. So communicating with the adolescent, I think, is probably critical. I mean, the nitty-gritties around the physiology and the conditions, etc., anyone can take a book and read. But I think the trick around dealing with this particular group of patients, it's kind of getting them into your corner, or having them understand that you are on their side. And you get a lot of buy-in in that way. So communication skills in dealing with adolescents with long-term health conditions, I think it's absolutely critical, Prof.
That's wonderful. Thank you very much. And I think it's great that there's more of a realization, not just amongst the medical community, but amongst our administrators and our teachers as well. So I think that's really great. So I've asked if anybody wants to pop any questions or comments in the Q&A, and I think with that, I'm going to hand over to Tanya, who's going to introduce our next speaker. And Zax, if you don't mind hanging around, because hopefully at the end there'll be some further discussion. But thank you very much from my side.
Thank you.
Thanks, Mignon, and thanks to Zakira. I think that was a lovely, definitely a wonderful presentation. And Mignon, your personal reflection on your experience has actually been was actually lovely as well. And I think we're a small enough group that if other people want to share their personal experiences of dealing with adolescents, I think we'd welcome that. So if anybody wants to, please just let us know in the chat. But I'm going to hand over to Rebecca now. So Rebecca works at the HIV service at Reproductive Hospital in the Department of Pediatrics and Child Health. She has been there for over a decade. And she's the coordinator of the Adolescent Clinician Group at Reproductive, as well as the coordinator of the Better Together group, where adolescents of a variety of conditions meet weekly in structured group activities where they just provide support to each other. Her experience is in the management of adolescents with complex long-term health conditions, particularly HIV, and she focuses on teaching them to live their best life with HIV. So sounds like we have a lot to learn. Rebecca, I'm going to hand over to you. Thank you so much for joining us.
Thanks, Tanya, and thanks very much for having me. Though I'll be talking about some of the common issues that come up when treating adolescents living with HIV, I actually think that many of these challenges are relevant to any chronic condition in adolescents. Okay, so to start with, let's get an idea of the scale of the problem. In South Africa in 2020, there were 370,000 adolescents aged 10 to 19 who were living with HIV. And that's in contrast to 150,000 children aged 0 to 9. And looking at that, you can see the age-related shift in HIV among children. Thanks to the success of PMTCT, there are far fewer children who contract HIV in the perinatal period, and those that do are aging into adolescence. But the other component of adolescent HIV numbers comes from those who acquire HIV in adolescence, or the so-called behaviorally infected cohort. And in South Africa in 2020, there were 38,000 new HIV infections among adolescents, overwhelmingly among girls. And shockingly, for a condition for which we have effective treatment, 4,300 adolescents died of AIDS that year. Okay, so if you divide this group into those with perinatally acquired HIV on the left and those with behaviorally acquired HIV on the right, you'll see that they share some challenges. But the perinatally infected group also has several unique issues that arise from their early acquisition of HIV. I'm going to come back to mental health care needs later, so please just bookmark that for now. In general, perinatally infected adolescents tend to be cared for in pediatric services until the age of transition, while behaviorally infected adolescents often start treatment within adult services. So for a pediatric audience this evening, I'll focus more here on the perinatal group. As early infant diagnosis has improved and more children have started out in infancy, we're seeing less of these issues among our younger adolescents. But in older adolescents, or those where the diagnosis has been missed, we're looking at the sequelae of untreated childhood HIV, and that's issues like short stature, neurocognitive fallout, chronic and stigmatizing skin changes like PPE, and chronic lung disease. Particularly among those with poor adherence, we're seeing opportunistic infections, especially TB, but also frequent bacterial infections. Many of these kids have also spent a long time on art, and not all of it has been virologically suppressed. So as a result, some of them are highly treatment experienced and might have complex drug resistance profiles that limit their current medication options. And then lastly, HIV is a family disease. So our perinatally infected kids experience high levels of orphanhood and unstable family dynamics. Again, this is less prevalent among the younger adolescents whose parents have often accessed art in time, but it's still a reality among many of our older adolescents. So to illustrate some of the specific challenges we see in this group, I want to share a fairly typical case. I've picked a case from a few years ago, so I can give a bit of long-term follow-up on what happened to this patient. So she's a 16-year-old girl diagnosed with HIV at the age of 6 and on art since she was 10, which was according to the guidelines at the time. She was started on a regimen of abacavir, lamivudine, and efavirenz, and she did well on that until her adherence started to wobble at around age 13. As a result, she had virological failure, and at age 14 was switched to a second-line regimen of zidovudine, lamivudine, and lopinavir ritonavir. She initially suppressed on this, but she didn't stay suppressed for long. And so the last viral load before this consult was 122,000 with a CD4 count which had dropped from over 500 to 317. On her past medical history, she'd had pulmonary TB when she was 10, but otherwise had been generally well. And on social history, she lost her mother to AIDS-related complications when she was 4, and she moved to her granny. Then her granny died when she was 7, and she moved to her aunt. Her aunt also has her own children. And at school, she's in grade 10 and passing. So this child arrives at the consultation with her aunt, and auntie is furious. She's missing a day of work to be here, and she has a long list of complaints about the child's behavior. According to her, the girl is cheeky and defiant. She's staying out late with friends and chasing boys, and auntie has had enough of nagging her to take her medication and getting rudeness in return. It's time this girl took some responsibility. Throughout the aunt's speech, the child is slouched in her chair, she's rolling her eyes, and all that she will say is that she's just bored with taking medication. When I send the auntie out and speak privately with the child, she becomes tearful, and she says it's not fair that she's the only person in her house who has to take treatment. Nobody understands what she's going through. Often she's in a hurry in the morning before school and she just forgets to take treatment. But when she does take it, it makes her feel very nauseous at school. She finds her auntie's house rules excessively strict. And in fact, she does have a boyfriend who she hasn't mentioned to her aunt. She and her boyfriend have not discussed HIV, but she says that he mostly uses a condom when they have sex. The child's examination is unremarkable, and to everyone's relief, her prognostic is negative. Okay, so I'm sure this basic scenario is very familiar to anyone working with adolescents. I want to pull out some of the key issues here and spend a little bit more time on each one of them. Firstly, we obviously have an adherence problem. The caregiver and the child agree that things are not going well with the pills, and we can see this reflected in the blood results. She's got an extremely high viral load, and she's starting to develop CD4 decline. If this continues, this child is at risk of disease progression as well as potential drug resistance. She's already on a second-line regimen, so we really don't want to use up all her treatment options before she reaches adulthood. Secondly, we've got the child's behavior, which might just be normal teenage rebellion, but it's impacting adversely on her health. And underlying this, potentially, is a mental health problem. This girl seems to be feeling isolated and stigmatized as a result of her chronic condition. And then thirdly, we have her sexual and reproductive health needs. We have a good opportunity here to help her to make safer choices. In particular, we'd like to help her to avoid an unwanted pregnancy, to prevent and treat any STIs, and though we don't know her partner's status, we'd like to prevent transmission of HIV to him too. And in my experience, addressing these three issues, adherence, mental health, and sexual and reproductive health, takes up most of my consultation time with adolescents. So let's take them one by one, starting with sexual and reproductive health. I think that this is an area that is often neglected by pediatricians as well as adult physicians. But if we aren't addressing our adolescent patients' sexual and reproductive health needs, they aren't necessarily going to seek this care elsewhere. So it's really vital that we take the opportunity to proactively engage with them on this. Of course, adolescents of the same age can have very different needs. So one 15-year-old may already be sexually active, while another is very far from that. I like to talk to all of my adolescents about safer sex and contraception, whether or not they have a partner at the time. For those that have never been sexually active, I'll just tell them that whether this is relevant to them in 2 months or in 10 years, it's important that they know what their options are and how to make safe choices. And I'll always emphasize that if things change or if they have any questions, they can come back later and ask. These conversations can usually be a bit more honest without the parent in the room, but many parents are actually quite grateful that someone's talking to their child about these issues. Talking about this also allows us to screen for abuse, which of course we're obliged to act on if the patient is under 18. For the girls, ideally it's best if we can offer on-site long-acting contraception. We can educate all we like, but it takes guts and another day out of school for a teenage girl to go to a different site to access contraception. If we can remove that extra step, it's that much more likely that it will actually happen. An adolescent of 12 years and above can consent to contraception without parental involvement, though of course it's always nice when a parent is involved. Okay, moving on to adherence and how adherent are adolescents to art? Well, surprise, surprise, as with so many other chronic conditions, adolescents living with HIV are poorly adherent to their treatments and have worse adherence than either children or adults. There's conflicting data on whether boys are particularly non-adherent, but what is clear is that adherence gets worse over the course of adolescence. So older teens are less adherent than younger ones. As an example, when we did a retrospective review in our service at Reproductive, half of all of our adolescents in care had experienced a sustained episode of detectable viral load, and 19-year-olds were 20 times more likely than 10-year-olds to have an elevated viral load. In addressing adherence, we have to address the drivers of adherence, and I'm going to divide these into 4 broad groups, bearing in mind that these overlap within the individuals. And I'll start with the simpler ones, that's medication and routine factors. Okay, I'll make a really obvious point which isn't unique to HIV, but the medication we prescribe causes side effects. If these side effects are unacceptable to our patients, they won't take the medication. In the case I've described, the medication was making the patient very nauseous at school, and GIT side effects are extremely common across the protease inhibitors, but especially with lopinavir ritonavir. We need to counsel our patients on potential side effects before starting them on a new drug and discuss what to do if they do experience them. We've also got to keep screening for side effects because they can develop later on. And then when our patients experience side effects, we need to take them seriously and change medication where possible or treat the side effects where it's not. Secondly, our adolescent patients really appreciate a daily dose. So many of them struggle to take pills before school or live in households where they only have medication supervision once a day. Even those patients who are coping on BD regimens are so grateful when we can change them to a daily dose. So it's really worth looking at the available options and seeing if we can simplify their regimens. And that brings me to the really fortunate situation that we're in with HIV at the moment, where more adolescent and adult patients than ever before are eligible for a single pill a day regimen. The introduction of dolutegravir-based ART has been a real game changer in the field, and we're in a situation where most adolescents on first-line regimens can now be switched to a fixed dose combination containing tenofovir, lamivudine, and dolutegravir. It's one pill, it's not even a very big pill, only once a day, and it's very well tolerated. The HIV Clinicians Society has just published guidelines for how to use this appropriately in second-line regimens too, so we're hopefully soon going to see many of our adolescents taking radically simplified regimens. If you have adolescent patients on ART and you need some guidance on whether it's safe to switch, I can really recommend the HIV and TB healthcare worker hotline. I've put that number up on the slide. They're very friendly people and they will advise on matters both simple and complex. Okay, then moving on to routine factors. As much as possible, we need a stable caregiver on board to supervise treatment. This is a contentious issue among adolescents and their caregivers because adolescents resent being babied and caregivers often feel that the adolescent is old enough to take medication alone. I think it's useful to anticipate these issues starting in early adolescence and counsel caregivers that although their 11-year-old may take his treatment very compliantly, it's very normal for teenagers to forget their medication and to resist it sometimes. So they need to remain vigilant as the child gets older. It's an obvious point, but reminding a child to take their medication is not the same as supervising them. So we need to be clear that the caregiver actually has to witness the pills being swallowed. I have these conversations with the teenager in the room. In fact, I try to avoid having any conversations with a caregiver without the adolescent present. And I'll usually tell the adolescent that it's totally normal to have days when they don't want to take their medication or when they forget to take it. And their caregiver's help is for those days. We do want to encourage responsibility, so a good strategy seems to be to try to get the adolescent to bring the medication to the caregiver and take it in their presence. If the caregiver takes chronic medication themselves and we can match the timing so that the child and the caregiver are each other's supporters, then so much the better. ARVs don't need to be taken with strict timing, but matching them to a time-based activity like a TV show can act as a reminder. It's also important to plan exceptions to the routine. So I might say, you usually take your pills with generations at 8, but what if you're staying over at your friend's place and you're leaving at 5? And the adolescent can problem solve right there in my room and might come up with an idea that she'll take her medication at 4 o'clock on days when she's staying out. And then I can validate that as a safe strategy. In general, the medication and routine factors are the easy things to get right. Psychosocial barriers to adherence are much more complex to address, and unfortunately are very common among this cohort. Although HIV affects all economic groups, it disproportionately affects the poorest. So our adolescents often come from households which struggle with financial insecurity. It's an obvious and a sad point, but for a family living below the breadline, there are more immediate priorities than taking medication every day. As a result of high levels of orphanhood, adolescents sometimes bounce around within their extended family, and it can be difficult to pin down a stable caregiver, which makes supervision challenging. As well as these social challenges, adolescents living with HIV have higher rates of mental health disorders than their uninfected peers, and that goes for perinatally and behaviorally infected teens. A recent systematic review on adolescents living with HIV in sub-Saharan Africa found that 16 to 41% had major depression and 2 to 25% had anxiety symptoms. And then there are the other common psychological issues like stigma, isolation, grief, and anger. All of these contribute to poor adherence to art, but are also significant causes of morbidity and distress in their own right. These issues are so common and many are treatable, so we really need to screen for them. A drop-off in adherence can often be an early sign that something's going wrong, so we need to inquire specifically about mood and anxiety symptoms. But once we've picked up a mental problem, we need to deal with it, and it's here that the multidisciplinary approach is key. What this looks like is very setting dependent, and especially for those of us in the public sector, we often struggle with a shortage of mental health professionals. If it's a possibility, it is so helpful to involve a psychologist or a psychiatrist in care, ideally integrated into the clinic so that if an adolescent has a mental health concern, they can start receiving help the same day. A social worker with a feel for adolescents can also be very useful here. Adolescents are very influenced by their peers, and we can harness this by linking them to peer support. This can take the form of mentorship, where they're linked to an older adolescent or a young adult who's doing well on treatment and can act as a role model. It can also take the form of peer support groups. Setting up a support group is a very low-cost intervention, and there's increasing evidence for their effectiveness in improving adolescent mental health and adherence. I want to tell you briefly about the Better Together group that we run at Reproductive, which is unusual in that it brings together adolescents with any chronic condition who attend the hospital. So we have teens with HIV, with renal disease, psychiatric conditions, respiratory illness, and more, all in one group. It's a weekly drop-in group, so adolescents usually come when they have an appointment or are fetching repeat meds, and those who are admitted to hospital attend when they're well enough. Groups are run by trained peer mentors from various clinics in the hospital, as well as clinicians who contribute sessions. Our teens have told us that they're sick of talking about their illnesses, so instead we focus on topics that really interest them. That's things like relationships, social media, sex, future planning, and friendship. Some groups get very serious and others are much more lighthearted. We're in the process of formally evaluating whether group attendance has an association with mental health outcomes, but the programmatic feedback we've collected so far has been extremely positive. These are some of the qualitative responses we've received. I don't feel as alone as I used to. It has made a huge difference even in my life coping with my disability. You come out of that group feeling more alive than when you went in. One of the things that's been exciting about these groups is that mixing adolescents with different conditions has been really successful at providing support. So an adolescent with HIV might form a friendship with someone with renal disease. They both feel that their friends don't understand what it means to have a chronic illness, but in the group, to quote another response we got, everyone's living with something. So before I close, I want to return to the case study from earlier and just give some feedback on our interventions and the outcomes. In dealing with our patient's adherence, we addressed medication factors and switched her to a daily regimen that was of Truvada, Atazanova, and Ritonava, and that also has a more favorable GIT side effect profile. We agreed on a routine of taking pills in the evening, but with a plan to take them in the afternoon when she's going out. We never quite resolved the issue of supervision with her aunt, though. For her sexual and reproductive health, she commenced Pediatric, which we keep as clinic stock, and we timed her clinic appointments to match her injection dates. She actually did end up disclosing to her boyfriend and even brought him into clinic for testing, which I admit is unusual. He tested negative. And in terms of her mental health and behavior, she was assessed by our social worker, who didn't think that she needed psychiatric evaluation. Instead, she was referred to join support group. After these interventions, her viral load 3 months later was 22, and 6 months after that was undetectable, with a CD4 that had recovered to 716. She's had the occasional adherence wobble since then, but has mostly remained suppressed. She's remained on contraception consistently since then and is nulliparous by choice. And in terms of her mental health, she's done very well. She really enjoyed groups and became a vocal participant who would attend every group in school holidays to catch up with her clinic friends. After matric, she trained to become a peer mentor in our service, and she currently runs groups as well as mentors younger adolescents in the clinic. She and her aunt never saw eye to eye on boyfriends and staying out late, but she has been able to harness her own difficulties during adolescence to connect with younger teens who may be going through similar things. So to sum up, in South Africa, we have a large cohort of HIV-infected adolescents, many of whom struggle with poor adherence. When we treat these patients, we have an opportunity to simplify their treatment regimens and collaborate with them and their caregivers on their medication routines. These adolescents also have a very high burden of mental health issues, which we need to screen for and address using a multidisciplinary strategy. Peer support is a low-cost intervention that can help with this. And lastly, we owe it to all adolescents to address their sexual and reproductive healthcare needs, ideally with the opportunity to access care on site. Thanks very much, and I look forward to having the chat afterwards.
Thank you, Rebecca, for a really lovely presentation, for all the great work that you do. Before we started, my planted question was going to be, what are your tips for adherence? But I think you've covered that so well in the presentation. I think for me, one of the issues, and we're only going to have 2 speakers today, but the 3 themes seem to have been sort of renal and transplant patients. We would have had diabetes, and we also had HIV, is that it really seems crackers to be taking medicines when you're not feeling sick. And it's really hard to try and explain to people why they should be taking medication because they're feeling well. Why should they carry on taking medication? And that does make a lot of sense in my mind. I think I would also, if I was a teen and feeling particularly well, why on earth should I be taking medication? But the problem for all 3 of those themes is if you're not taking your medication, the chances are that you're going to die. And then we're going to be walking down the palliative care route with you as well. And that, I think that for us is really hard. So little tricks that we've done is similar to you. I scout the pharmacies that I go around looking for pill boxes to try and give the patients that, so that at least on a Sunday night they can maybe sit with their carer and fill a pill box. Like you, we also encourage the carers to be observing and not just saying, have you taken your medicine? Because otherwise the medicine ends up in the pillowcases, in their panties, in the toilet and everywhere else. Using a smartphone for an alarm device sometimes works quite nicely. And I really love it when the carer does have their own comorbid condition, not because they've got a comorbid condition, but because we say, then make it a team effort. It's like the soccer team. In the morning, everybody has breakfast together, everybody takes their medication, and they don't make a big deal of it. But we sometimes have patients, and that's a sign of the times, that come in and tell us, well, they didn't take their medicines because they didn't have any food in the house, so they couldn't take breakfast, so they couldn't take their medication. So we have an ongoing discussion with our pharmacy saying, please don't tell the patients they have to eat something, at least just get the medication in. So I think those are the issues that we've struggled with. For renal, it's particularly hard because we know that if they are seen as being non-adherent, they may not make it onto a dialysis program or a transplant program. And it just is tragic that death can be the succession of poor adherence. And so for us, it's been really, really difficult to try and come up with bright ideas. And your ideas are fantastic. I think a buddy system works really well. The peer mentors works really well. And as you say, it's a low budget involvement. So it's worked really well. In fact, as you know, it's worked sometimes too well in that some of our peer mentors have actually now gone and got married, which I don't know if having 2 renal patients, both with renal issues, getting married was what we had planned, but it just shows what a happy working space you've created for them. So just want to say a really big thanks to you for all of that. And I am really passionate about adolescents because I think we owe them. It's tough growing up, it's tough being a teenager, and it's really tough having a chronic illness. So I was just going to ask Zax if she had any other ideas about adherence before we move to the questions and answers, and I know that Ziad is going to chair the Q&A. Zakira?
Yeah, so I think between yourself and Rebecca, you guys have largely covered, the general points. In fact, just this afternoon before I came back to Red Cross, I saw a young lady who was a newly diagnosed epileptic, and at her last visit in March, she had had such exceptional control of her epilepsy that I had had the discussion of possibly, trying her off meds, and because she'd been 2 years seizure-free. And then suddenly, in the last 3 months, she's now had 5 breakthrough seizures, and things have just gone, sundry with her. And when we really got down to talking about it, there's just a lot of stuff. It's the hormones and everything's raging, and she's upset about this diagnosis, and she stays in a boarding school, and what will her friends say if they see her taking her pills? And so we really had to sit down and just explain, go back to the basics. And I think once I had mapped out for her the need for her meds, and that having the seizures were actually more of a problem than taking the medication, I could see that realization dawn on her face. And so again, it just comes down to, I think, having clear conversations with them. When she understood that if I don't take this is why I'm having the frequent seizures. And if I'm having more and more seizures, it's not going to be good for my brain. And I'm a high school learner who have got big dreams for myself. So, we can strategize, and but really, I think at the end of the day, it's about getting their buy-in at the end of the day. It's literally convincing them that they've got to do this for themselves. And, in terms of taking care of themselves. And I think it's that communication. And then, yes, the peer mentors. And, we had already, she'd spoken about the phone. And then I suggested leaving her pill box next to her toothbrush, so that when she brushes her teeth in the morning and she brushes her teeth at night, it'll act as a reminder, my pills are there, I need to take them. So yes, I think it's just thinking up novel ways to promote the adherence. But mostly, I think if you can get them to understand why they need their meds, then that's half the battle won.
And I think, if you look at all of us, if we have to take antibiotics 3 times a day just for a 5-day course, we all struggle. So somebody once said, with teenagers, you can never take your foot off the pedal. You need to keep that support going. So thank
Absolutely.
you very much. So I'm going to hand over to Tanya and to Ziad for the Q&A.
Thanks, Mignon, and thanks to our speakers. It really has been a very interesting afternoon of talks. There are a couple of questions in the chat that I do want to pose to our speakers. And there was one that isn't specifically a question, it's a comment that was made, but I think we can turn it into something of a question. And that was in using the arts. So somebody suggested that music and drama might be something of an avenue in terms of coping or gaining insight into the illness. Do either of you have any reflections on that you'd like to share with us?
Yes, so our SACAP counselors at ACE, they have introduced some really novel techniques, to draw that adolescent patient out. For the most part, Tanya, it's quite unusual to encounter an adolescent on the first visit who's ready to open up and talk. So they take a while before I think they check you out. And if they trust you, then, you're going to get places. But I've seen our counselors, they've got this beautiful space upstairs where they let the patients paint. I've actually walked past and I've seen one of our counselors sitting with a young boy who largely speaks in just grunts, and the two of them they were playing dominoes, and it turned into a very loud, and dominoes is a very big Cape Town thing. Everyone plays dominoes and people really enjoy it. And at the end of that session, the counselor actually popped back into my office and said to me, what they did. He set out some rules, and he said, we're going to play this game of dominoes. And there was like, if the blocks land on a certain number, then you're going to tell me something about yourself. And if the blocks land on another number, I will have to tell you something about so it's a very novel, and they spent an hour doing and throwing over a dominoes game, but it turned out really well. And so we have a lot of painting going on. We really have the kids expressing themselves in different ways. And so the counselors have come up with fantastic ways actually to engage with the patients at the center. And I think that we try and use avenues that they can relate to. And so social media, music, art, all of these things are certainly avenues that we can't ignore in our armament. 100%.
Yeah, amazing. Rebecca, is there anything that you'd like to add to that?
I mean, just to mention that some of our most popular groups have been karate and yoga groups as well, where we've had outside people come in to do these activities. And 40 minutes of the session is on a physical activity, and then afterwards these kids feel so bonded together. They often have very meaningful chats at the end of that session and kind of walk out with a spring in their step.
Gosh, it really, it really does sound like a very different field of medicine, which I think we could definitely benefit from exploring more, because you just express your own creativity and learn a lot about yourself in it as well, it seems like. There's one question in the chat that I want to pose. Let me just read it out. So what is your advice for the adolescent who volunteers another adolescent with their own chronic health condition or chronic condition as a supervisor? Can one teen support another in this way from your experience? Or as I've seen it happen at times with teens with eating disorders, they can fall into their trap of reinforcing unhelpful or self-destructive choices. When you want to take that, it's quite a loaded question, but
I can take it just speaking very practically as a treatment supporter. I don't think that another teen is responsible enough to be a treatment supporter. I just, if the first teen is struggling to remember to take pills, there's not a good reason to think that the second teen is going to be able to do it. And teenagers tend to be wonderful at taking, a motivated teenager is also just wonderful at taking pills until they forget. But I think another teenager can absolutely provide psychological support and friendship. And that's one of the things, for example, that we're trying to get going in the group, is that our group participants will make friends with other kids with chronic conditions and provide support that maybe they don't get in their families or among their peers who don't have a condition. So I think it's kind of a yes and no answer.
I agree, Rebecca. I think I've seen the benefit of that peer interaction in our FIT club. Just to see the friendships that have grown. In our first cohort of participants in the FIT club, they're a group of 8 morbidly obese adolescents, and I can just see that they have each other's back. But I think coming into that space and exercising together, there's so much laughter, there's so much, they just provide that support and I think it's emotional more than anything. I think it's just having someone who gets where you are at. And for a teenager, I think that's it's highly beneficial. But yes, I think that we do umbrella and kind of provide that canopy over the whole system. So we keep an eye on them closely, and certainly, Rebecca, I agree that the support is more from a friendship, emotive, psychological, I think, kind of support. That would be my comment.
Okay, thanks. Then I have another question that relates to, and as Zakira, you mentioned the transgender clinic, and I know our endocrinologist wasn't able to join us this evening, But in the context of gender dysphoria, and I think that's probably increasing at the moment, are there any comments or reflections on that, and what just general advice on what to do when we come across a patient?
Yeah, so I was really hoping that Ariane would be here because I was expecting a question along these lines. And I must say that, yes, we've certainly seen an upsurge in the number of referrals for young adolescents with gender-related questions. And, you know, for the large part, we'd like to refer to it as gender dysphoria. But at which point does it actually become, you know, a concern? So our counselors are obviously skilled enough to engage in session with these young people and explore whether we are just dealing with a transient sense of dysphoria or whether this is actually something pathological. So screening methods are in place, and the mental health aspect, obviously, of a child with gender issues, I think, is critical. So I think I would encourage anyone who is obviously engaging with a young person who walks into their rooms and, you know, reveals that this is an issue or they're struggling with it, is actually to refer for mental health assessment and appraisal. I have found them most useful in terms of, you know, a starting point, because I think many of these teenagers, they will present with depression just because of their uncertainty or because of, you know, the questions that are going on in their minds. And so what actually comes up is that they may present with symptoms and signs of depression, but the psychiatric teams, the counseling teams, the psychologists, etc., I think they are very well perched to pick up on what the root of that depression actually is, and then, you know, take it further from there.
Okay, amazing. Thank you. Okay, and so I think that's it. We don't really have any further questions. And so I'm just going to tell you what my takeaway from this evening has been. And the primary thing is that it sounds like communication is really the superpower that makes adolescent medicine go around, and something that we all need to learn and practice every day.
100%.
Particularly, I mean, just in addressing things like their treatment and mental health, and really that if they understand, they will actually, they won't be non-adherent. We can't label them as such. For me, I think that was a primary point, and just like letting that penny drop and getting them to that point. I think both speakers have been absolutely amazing. Thank you so much. It's really an insightful evening that we've had.